Good morning, dear friends. Today is the next lecture, and it is devoted to further features of the joints, and we are going to talk about the anatomical features of limb joints. As I see, today there are about 6 students in our anatomical studio. As usual, I'm together with you. My name is Dmitry Starchik, and I am ready to start. If everything is fine with the connection, I hope it is. Okay, let's switch to yes, that's right. That's all right. You put your name and group number in order I can see all students who visit our lecture. Well, thank you. And I hope you guess that human skeleton needs to move, but bones are too rigid to bend without being damaged. Fortunately, flexible connective tissue hold bones together at points of contact, and these points we call joints. Joints permit the bones some degree of movement. Think for a moment about the amazing range of motion and the complexity of the coordinated movements that occur as the bones of the body move against one another. Many joints action are repeated daily and produce continuous work from childhood and throughout our adult lives. How does joints make this incredible staying power possible? Why do joints sometimes fail and cause our movements to become painful? And how can we prolong the efficient function of our joints? We will find answer to this question in our lecture, studying anatomy section termed arthrology or arthrosyndesmology. Let's get started. By the way, here in the picture you see Russian gymnast, world champion Julie Guntel, who has got incredible movement in her joints, and she is number 1 in the world. We start from upper limb joints, and you see the classification of upper limb joints. As you guess, all types of bone joints are present here, and we can divide the all joints of upper limb in the upper limb girdle joints. This is the first group, and the second one is joints of the free part of upper limb. Here you see the upper limb girdle, and here all of these bones are connected together with the joints of the free part of upper limb, because that is the free part of the upper limb. The joints of upper limb girdle, we also call it pectoral girdle. In comparison with the pelvic girdle, are homologous. Homologous, this term means that organs are similar in origin and structure, but homologous organs perform different function. Typical example of homologous organ are pelvic girdle and pectoral girdle. You see here pectoral girdle in I hope this is a brown color, and the pelvic girdle is blue. What is the difference between pectoral and pelvis girdle? The pectoral girdle, as you know, is composed of 4 bones: 2 scapula and 2 clavicles. They are connected to the body only in front, here, and clavicles are connected to the sternum. And the main feature of the shoulder or pectoral girdle is that this girdle is not closed behind. So here it is opened. Another situation we see in pelvic girdle. Pelvic girdle consists of 2 hip bones, one and left and right, one and second. They attach behind to the sacrum. Here is quite large joints connecting pelvic girdle with sacrum. And this girdle also is closed in front, and 2 pubic bones connecting in the pubic symphysis. Pelvic girdle is closed and forms an osteoarticular ring, and you see this ring as a rigid and stable structure. We call this structure pelvis. That is the main differences between the pectoral and pelvic girdles. Joints of pectoral girdles, we start from these joints, have got three main joints. First one is acromioclavicular joints. Second one is sternoclavicular joints, number 2. And the third one is scapula-thorax connection. It is between anterior surface of scapula and thorax. Let's talk more about features of the pectoral girdle. In comparison with the animals, the joints of pectoral girdle form a half ring that open back. I told you already about that. And sternoclavicular joints, this one, connecting clavicle and sternum, is very mobile. It is necessary because it allows to move shoulder joints very easy and give to shoulder joints maximal range of movement. Scapula in the humans located on the dorsal surface, and it's oriented vertically. It means the vertical line, the high of the scapula is oriented vertically. If we see the animals, that main differences is that they don't have claviculas. So is in dogs, cows, sheep, there are no clavicles at all, and the scapula oriented transversely, not vertically. Like in human it is in this position, but in animals it is oriented in the transversal position, something like this. And the fourth difference is that clavicular serves in humans, clavicular serves to move the shoulder joints to the side. It means that these shoulder joints located more laterally than in animals. It is necessary for using upper limb as an organ of the work organ, labor organ. Joints of the first joint of the pectoral girdle is acromioclavicular joints. It is located here, and each clavicle forms one joint with the scapula, and between the acromion and acromion part of the scapula. Acromioclavicular joints has triangular intra-articular discs inside. It means that the gap or joint cavity on joint gap is incongruent, and inside we find triangular disc. This joint is plane and the movements are insignificant. They are performed mainly due to the elasticity of the cartilage. So usually we don't have large movement in both acromioclavicular joints. Because of the two ligaments connecting clavicula and scapula, especially this coracoid process, the movement is movement in the acromioclavicular joints is small, and two of these ligament we call trapezoid ligament. It is located more laterally, and conoid ligament located medially. Because of this strong ligament, when people fall on an outstretched upper limb, it follows the dislocation of acromioclavicular joints, and sometimes it comes to injury to the coracoclavicular ligament, as you see here. The articular capsula is damaged, is torn, and also ligament, one or both ligament having damages. Next, joints located between medial part of clavicula and sternum, and it is called sternoclavicular joints. In Latin, articulatio sternoclavicularis. This joint is saddle joints. In 95%, or very rare, it is spherical joints. Usually it is saddle joints. As you see, there is also a disc inside the joints. Therefore, such joints having disc or menisc inside we call complex joints. That is also is not an exception, and we call sternoclavicular joints as complex joints. The disc and articular surface are made of fibrous cartilage. This is very strong cartilage, which always under high stress, because the clavicula keep outside, and this connection between clavicula and sternum is pressed all the time. These sternoclavicular joints has also powerful ligamentous apparatus or ligaments, and you see here between two claviculas interclavicular ligament is located. There are anterior sternoclavicular ligament and the posterior sternoclavicular ligament in these joints, and very strong ligament located between the first rib and inferior surface of the clavicle. Because of these powerful ligaments, these joints usually is not get dislocations, and more often we see a fracture of the clavicle, like you see on this X-ray diagram. Because of fixing the clavicula and fixing of the clavicula in both sides, usually we get fracture in clavicula instead of dislocation into these its joints. Joints of the scapula to the thorax is not joints. That is the intermuscular junction. Here you see this junction. This is the scapula here, and this is the thorax with the muscles, and one large muscles covers the anterior surface of scapula, and this we Алло?
Здравствуйте, Дмитрий Анатольевич. Галкина Екатерина Юрьевна.
Здравствуйте, Екатерина Юрьевна.
Ученый совет. Да, вы планируете быть на ученом совете?
Обязательно, да.
А могу я вас попросить счет за комиссию?
Можете. Да.
Благодарю вас. Я вас назначаю счет за комиссию. Вызову, выходите, пожалуйста, на стол. Ладно?
Спасибо, договорились. Спасибо, хорошо. До свидания. Угу. Sorry. And the gap of this connection located here, and as a tip of the junction, that is the intermuscular junction. So that is not joints at all, but it gives great freedom of movements to the scapula and also for the pectoral girdle. Don't forget that this type of connection is not joint, but that is a intermuscular junction. Next group is joints of free upper limb. First joint we are going to talk about, called glenohumeral, or more often term we use as a shoulder joint. This joint is large, and some of its feature you see below. First of all, these joints has a large difference in articular surface between scapula and between head or caput of the shoulder bone. As you see, the difference is in 6 times more. It means that the surface on the head of shoulder bones is 6 times larger than the surface on the scapula. This factor gives quite big freedom for movements, but this is also the negative feature, because in these joints we have a half of all dislocation in our body. That is the most dislocated joints. The joint has elastic capsula, and it is reinforced with just one ligament. It calls glenohumeral ligament. Glenohumeral ligaments is located on the superior surface of the joints. And as you see, the shoulder joint has got 3 protrusions of the synovial membrane, or the articular capsula, in other words. Here you see axillary pocket, that is the largest one. Then the synovial vein for a long head of the biceps, number 1. And second one is the tendinous bursa of the subscapular muscles. Here usually goes the subscapular muscles, and between the tendon of these muscles and anterior surface of the joints located these bursa. In X-ray examination, we see normal left picture is the normal shoulder joints. We see the articular surface of the scapula and a large articular surface of the head of the shoulder bone. And we also see here acromioclavicular joints, and the shadow here is the shadow of the coracoid process. Right picture shows dislocation of the shoulder joints, and as you see, the weak point is the inferior part of the capsula. Because of that fact, the head of the shoulder bone this is dislocated down. Usually typical down dislocation. It is a standard in dislocation of the shoulder joints. Next picture, I show you this dislocation clinical situation when doctors try to make a reposition of the shoulder joints. And it was successful, but as you see, it was a little bit painful. Next, joints of free upper limb is named elbow joints, elbow joint. This is complex joint because it is made from three joints: humeroradial, that is here or here, humerulnar joints between ulna and humerus, and proximal radioulnar joints, it is here or here. Total movements in these joints are flexion, extension, and rotation with two types called pronation and supination. Clinically, sometimes in pediatry, the children may have dislocation of the ligament fixing radial head to the ulna, and it happens during the pulling the upper limb, like adults sometimes do, and it comes to the compression of the annular ligament between radius and between humerus. Joints of between the radius and ulna, one of these joints, we call it proximal joints, located in ulna, in elbow joints, and the second one is between the caput or head of ulna and surface of the radius, and two of these joints, I mean proximal and distal radioulnar joints, are combined. They are combined joints, and combined axis of movement, you see this axis in red here, is usually has vertical orientation, and here you see the movement into these joints as a resulting joints, and it calls pronation when the menus, or when the radius is located frontally to the ulna, and then the opposite movement when it comes back to the lateral position, called supination. So that is supination, but this is a pronation. P and S as a main letter of these movements. Usually two these antebrachial bones quite are fixed quite good with the interosseous membrane. This is a type of fibrous connections, and because of fixing, it's no movement around sagittal axis. But when people lose the menus, and surgeons, first surgeons who uh, developed this operation was German surgeon Krukenberg, and he invented operation in resulting the claw, and such form of antibrachium give people possibility to use the antibrachium as a claw, and to serve themselves after injuries, during, usually it happened during the first and the second World War in last century. Wrist joints located between radius and between three carpal bones, like scaphoid bone, lunar bone, and triangular bone. Usually this joint is ellipsoidal. It has ellipsoidal surfaces, and it has two axes of movement, sagittal and frontal. So we have 5 type of movements in the wrist joints. Please notice that the ulna is out of the wrist joints, because there is the disc between ulna and the carpal bones, and this disc is isolated. The disc isolates ulna from the joints. Between carpal bones we see quite large joints called midcarpal joints, and these midcarpal joints is look like it has a S shape, and works as a trochlear joint. Usually joints between carpal and metacarpal bones is flat. Only one exception we have for the first carpometacarpal joints. We call it thumb carpometacarpal joints, and this, you see the gap or cavity of these joints on the plastinated specimens. And this one, first carpometacarpal joints is not flat, it is saddle, and it gives to the thumb quite free range of movements. and we call these movements as opposition and reposition. In front of the carpal bones, we find quite a strong ligament located between lateral and medial bones, and we call it as a flexor retinaculum because it fixed the tendons under the in front of the carpal bones, and usually here located a lot of tendons of muscles flexing the digit, and we call this topographical structure between retinaculum and bones as a carpal tunnel. Here the isolated cavity of carpometacarpal joints of the thumb, and you see the opposition and reposition, which is a unique feature of human menus, human wrist. These joints is very important for humans having manual work, and surgeons try to keep it even if the other joints were damaged. They try to stay the part of the thumb, and thanks to these joints, carpometacarpal joints of the thumb, it is possible to serve themselves and walk and keep walking with the hand. Typically, functional position of the hand, which doctor use to immobilize the hand, is the we keep ball in the hand, and this is the degree of flexing some of the most joints in the hand. You see that the about 30 degree is a functional or physiological position for the wrist joint. Next is the lower limb joints. Classification is similar to the upper limb. We have lower limb girdle joints, we also call pelvis girdle, and the second group is joints of the free part of lower limb. Human pelvis girdle joints consist of the two pelvis bones, which are connected in front with the pubic symphysis, and posteriorly they connect to the sacrum with the sacroiliac joints, paired sacroiliac joints. As I said before, that is fixed construction, that is rigid construction, which usually have no range of movement. We distinguish two large joints here. First one is sacroiliac joints, then pubic symphysis, and arm joints of the pelvic bones. Let's see these joints in detail later. Special feature of human joints of pelvic gut is that they form a solid and immovable strong bonds because it is the bone rings. Pelvic girdle joints are well strengthened by ligament. We find a lot of ligament in sacroiliac joints and even in the pelvic symphysis. All of the pelvic bones, as well as the sacrum, give good protection for pelvic organ located inside. And another very interesting feature is that pelvis has pronounced sexual characteristic. It means the pelvis, the main pelvis and male pelvis and female pelvis are different. First joint I'm going to talk is the sacroiliac joints. It is located between auricular surfaces, located on the sacrum and on the hip bone. This is plain joints, but it fixed with the strong ligament, so we have no movements in these joints, and that is good. That is good because these joints we also call such unmovable joints as amphiarthrosis, and amphiarthrosis gives us the stable during vertical position. You see a lot of ligament located around the located on the pelvic girdle. First of all, very strong ligament between sacrum and ischial bones we call sacrotuberal or sacrotuberosis ligament, and the second one is sacrospinosus ligament. Here also located inguinal ligament between anterior superior iliac spine and pubic symphysis here, and we also see the membrane between ischial and pubic bones. By connection pubic bones, there is the type of joints we call symphysis. Symphysis typically has a gap instead of articular cavity. So that is not typical joints, but that is some kind of cartilage joints. Usually we find some of the ligament in the pubic symphysis, like ligament suprapubical and infrapubical ligament. Okay, and I would say that I should say that pubic symphysis has sexual differences, and the women has large, and usually women female pubic is like this. It means that distance between the pubic bones is larger than in male pelvic. Here you see pelvic ligaments located between sacrum. I just told you about that. First one is a strong sacrotuberal ligament because it connects tuber ischia with the sacrum, and the second ligament located between spinum of the ischia and sacrum, and two of these ligament form two openings. Big one is foramen ischiaticum majus, or large opening, and small one is foramen ischiaticum minus, and that is the gaps for where large vessels and nerves come out from the pelvic cavity outside. Here, sexual differences between male and female pelvises, and as you see, female pelvis has a lower height, and female pelvis usually has a ring between bones. Sometimes it similar to oval, but the male pelvis is conic, and opening of the small pelvis looks like a it has a heart shape, and angle under the pubic symphysis pubicus is small in male and large in females. Some of the distance in the pelvis are very important, just to prognose or expect or in expecting the process when women get baby, and the baby head come from the pelvis, and usually it is critical when the head and pelvis diameters is similar. We distinguish two of the main distance in the pelvis. Usually we measure distance between the premontorium and pubic symphysis. We call it conjugata vera, and also we are interested in the transversal diameter. Usually it is number 2, and these these diameters or measurements are important to know before the birth process is started. Here you see the conjugata anatomica. It is a superior diameter or superior conjugata, but more interesting to know the gynecological conjugata, which is between the posterior surface of pubic and promontorium of the sacrum. Usually this size is should be more than 10.5 centimeters. If less, doctor recommend women to have operation, but not and they don't allow birth process come naturally. Here you see the head of the child coming through the pelvis. As you see, it starts from the transversal position, then takes obliqual position and come out in the anterior posterior position. So all of the largest diameter of the pelvis, the head comes with the rotation from the lateral position to the anterior posterior position in the end of the birth process, childbirth process. Next joints are joints of the free lower limb, and the largest joints we call hip joints. That is the spherical joints which has some special features which is different than homological shoulder joints. First of all, we call such spherical and multi-axial joints as anarthrosis joints. They look like nut with the covering, with the shell of nut, and inside we see the caput of humera. Take a look for this ligament located between articular surface and the head of the femoral bone, and this is very important ligament because it provide arteries and veins coming from the hip joints to the head of the femoral and fix it close to the acetabular articular surfaces, and doesn't allow to have complicated in the development process. Hip joints has a lot of ligament located on the anterior surfaces, and they keep our body in vertical position. Next is the X-ray examination of the hip joints, and we see that typically and normal when the half of the femur head is located in the cavity of the in the acetabular cavity, and we usually see the chiton lines that is here, which is the normal or typical feature or typical characteristic of normal hip bones. Here you see hip fracture when the neck of the femur is destroyed, and that is a difficult, complicated fracture, usually without surgical operation and artificial hip joints. People may die because such fracture doesn't allow patients to move, and they have to keep horizontal position, and that is critical for a long period of time. Next joints is knee joints, which is a result of three bones: patella, femur surfaces, and tibia. We call such joints as complex joint because there are three articular surfaces in one joints. We also call knee joints as a condylar joints, biaxial joints, and compound joint because it has inside the meniscus two of some kind of cartilages located in the joints between the femur and tibia. Movements of the knee joints is around the frontal axis. We do flexion and extension. Around the vertical axis it's possible rotation, but only in the flexed position. When knee is flexed, then we can do rotation, but when the knee is extended like you see here, the ligament located laterally and medially doesn't allow rotation at all. Here is the X-ray examination, normal knee joints, and we usually examine this joint in the frontal and lateral position. You see the gap of the joints, and it is also visible connection patella. I hope you remember that patella is a sesamoid bone. This type of bones usually developed in the tendons, and as a joint, the knee joint has a lot of additional elements like synovial bursa located between muscles and tendons around the knee region. Anteriorly we find few bursae, and also on the posterior side in popliteal region we find some of this bursae which reduce friction friction during movements. Also, inside of joints in the cavity, we find two ligament. We call them crucial ligament. They keep femur and tibia together, and when people disturb this ligament, we see such movement like we call drawer symptoms. It looks like you take your box in your table, open the box or drawer, and close it back. So it's very typical for damaging crucial ligament inside of knee joints. Very often doctors replace knee joints with artificial surfaces, and it helps people don't feel the pain, because after when people get older, they feel they get problems with the knee joints, and to treat this pathology is difficult. So the replacement is the best way to give people better life. Between lower leg, between the lower leg joint, we distinguish two kind of joints. First is the real joints, true joints between caput of fibula and tibia. Here you see the gap or articular cavity, but the distal ends of the leg bones is not joints. It is syndesmosis. It means this is no joints at all. Here we see only ligament or some kind of fibrosis connection tissue fixed two bones together. It is necessary to get the surfaces for the ankle joints. Ankle joints typically is trochlear joints, because it looks like a trochlea, and it has only one axis. This is the frontal axis, and people do flexion and extension in the ankle joints. In Latin we call it articulatio talocruralis. These joints has a lot of ligaments located laterally and medially. We call medially ligament as a deltoid ligament, and there is also some X-ray picture of these joints. If you take a look, we usually examine frontal projection of these joints. In frontal projection of this patient, we see fracture of the lateral malleolus. This is a part of the fibula, and also when we examine children, we also see such. It looks like a fracture, but that is not a fracture. It is just growth zone. We call this zone epiphyseal cartilage. So don't be confused when you see such fissure or such gaps between part of the bones. And please don't put diagnosis, don't say that that is a fracture. Next, joints between the tarsal bones located between tarsal bone and calcaneus, and some of them located between cubital bones and navicular bones, and that is the combined joints which allows to flex a little bit, to adduct the foot. And there is also large and strong ligament between talus and calcaneus, and we call these joints in blue as the Shaparov talcal canal. In the we call it this transversal joints of the foot. Usually doctors amputate or cut in this line when the distal part of the foot is damaged during one or the explosions. Here you see some of flat joints between tarsal bones, and also the tarsometatarsal joints, which are combined in the transversal metatarsal joints, which also used for amputation, for evacuation during explosions. Human bones has special arches, longitudinal and transversal, here and here, and these arches of the foot help us to keep vertical position, and like a resource in the automobile and in some technical construction, they amortizate, or they do the shaking of the body during the walking, and reduce the shaking by running or jumping. And it is important because we keep the our vertical position all the time, and usually people doesn't work for the four limbs. We don't use the upper limb for moving, and this is a function of the lower limb. And these arches may be flat, and it calls flat feet. It is a problem for people, but now a lot of orthopedic mechanism which help to keep foot unflat. And sometimes we can check the flat feet just to see how look like the press when we press on the sand and see the result or picture of our food, and this is the normal when we had no touching between food and land, and the bottom, but the less free, the more contact we have between food, the more degrees of the flat feet we can diagnose. This is the interesting tradition in China when they bend the food in order to get small food for women, and it is of course not a health procedure at all, but that is the tradition. I think now that is the old tradition. No women no Chinese women do such thing now, because now they say that the long feet is not bad for women, and doesn't they have a chance to get married without bending of their foots. Thank you for now. This is all for now. Thank you for your attention, and I'd like to remember you that you have test today in the Moodle, which will be open till 19 p.m. till 7 p.m. today. Please don't forget to pass this test. And as usual, I have to answer your question if you have. And if you don't have question now, please send them to my email or to my mailbox, to the corporative email box we have, or put your question in the forum, in our forum. Thank you again, and hope to see you next Tuesday in our lecture. We will start to talk about the muscles. That will be myology, and I hope also you come to our university, and we will have offline lecture as we have for other students in the present time. Thank you very much, and have a nice day. My name is Professor Dmitry Starchik, and I am glad we have full lecture today. Thank you very much, and goodbye.